everybody. My name is Dave Cornell, the editor of Diagnostic and Interventional Cardiology magazine. On behalf of DAIC, we'd like to welcome everybody to today's presentation. It is titled Utilization of AI for Echocardiography Analysis and Outcome Prediction. Artificial intelligence has been implemented as a routine echocardiography analysis in recent years and has shown the ability to help minimize observer variation and help organizations optimize and standardize analytics. This includes automating view labeling, measurements, interpretation to support clinical decisions, and for ventricular outcome, for left ventricular volumes, ejection fraction, and cardiac strain. A global technology company, Ultromics, has been collaborating with many sites around the world to prove the quality of AI to help aid with clinical decisions. Their FDA-cleared and CE-marked product, EchoGo, is a new cloud-based offering that has been trained on millions of outcomes-based data. It provides zero variability automation for operators to obtain highly accurate and precise measurements and to detect and predict cardiovascular disease. Today, we will hear from Dr. Patricia Pellikka. She is the Vice Chairman of the Department of Cardiovascular Medicine at Mayo Clinic, and Dr. Federico Asch. He is the Director of Echocardiography Core Lab at MedStar Health Research Institute at Georgetown University. We will look at the results of the technology used at their institutions. You can read their bios by clicking on the Presenters tab at the bottom of your viewing window. We will be joined after the presentations by Gary Woodward. He is the Chief Technical Officer for Ultromics for a live Q&A discussion of the technology. We're going to get started in a couple minutes, but first I wanted to do a little housekeeping. You'll notice on your viewer that you have the ability to ask questions. We encourage you to ask questions at any time, and we'll try to answer as many questions as we can at the end of the presentation. Any questions that you enter during the presentation will go into the queue for us to use at the Q&A session. Any questions that we do not get to, we will answer offline. Our first presenter today is Dr. Pellikka. Currently, the identification of cardiovascular diseases by echocardiography, such as heart failure with preserved ejection fraction, remains subjective and challenging. Dr. Pellikka will discuss the utilization of deep learning applications in echo for the diagnostic classification of disease. This includes insights into how AI applications are being used and developed for automated image quantification and prediction of heart failure and coronary artery disease. And with that, I'd like to turn things over to Dr. Pellikka.
Thank you, Dave. Hello, everyone. It's my great pleasure to tell you a bit about the exciting research we've been involved with applying AI to echocardiographic images. My disclosures are that I receive research support for my AI echo work from the American Society of Echocardiography Foundation, Mayo Clinic, and Ultromics. We've been interested in the application of AI to echo images to detect heart failure. This is an extremely important subject because heart failure affects more than 26 million people globally, and the incidence is increasing. Echocardiography obviously plays an essential role in the evaluation of heart failure. Heart failure is a clinical syndrome, but we use echo to see if the ejection fraction is reduced, and in patients with preserved ejection fraction, if they have the constellation of diastolic dysfunction features identifying heart failure with preserved ejection fraction. To characterize diastolic dysfunction, we apply the recommendations that were developed by the American Society of Echocardiography along with the European Association of Cardiovascular Imaging. This is a very elegant expert consensus document, 38 pages long, with very nice tables and algorithms for how to assess diastolic function. However, sometimes diastolic function assessment is indeterminate. And how often would you expect that to be the case? Well, using the algorithms proposed, between 10 and 36% of patients have been noted to have indeterminate diastolic function. And so this is a big problem if we're trying to detect heart failure with preserved ejection fraction. And we come up with indeterminate results in such a large percentage. And sometimes this is because one of the essential variables is just not feasible. So in our project, we wanted to use limited echo videos to develop a deep learning-based model to detect patients with heart failure and preserved ejection fraction. We selected a control group without heart failure and with normal systolic and diastolic function. And the patient group, patients with clinical heart failure and grade 2 to 3 diastolic dysfunction and preserved ejection fraction by echocardiography. Our large Mayo Clinic database of 2.7 million echocardiograms is well suited to such a project. These are comprehensive studies, and we do a review of each echocardiogram before the patient is dismissed from the laboratory. Our laboratory is also a multi-vendor ultrasound system laboratory. And then we have a linkage to our electronic medical record. Moreover, this has really been the basis of my research for many years, linking echo features to clinical outcomes. I was inspired by the work that had been accomplished with ECG and echo. So in this project, we used paired echo and ECG data to detect left ventricular ejection fraction less than 35%. We developed a convolutional neural network, and you can see that the results here of our validation and testing set were extremely good for identifying left ventricular ejection fraction less than 35% from just a 12-lead ECG, nothing else. Here's an example from our clinical practice. This is a patient's electrocardiogram. You can see that there's sinus rhythm and APC, inferior Q waves, but our AI application estimated the probability of left ventricular ejection fraction less than 35% at 85%, so quite likely. And indeed, with echocardiography, this patient's ejection fraction was 35%. Now, the challenge with echocardiography is greater than that with electrocardiography, I think. This is the 12-lead electrocardiogram, but think about our echocardiographic study. Our average study is about 120 3-beat clips or Doppler images, and so the size is massive, 400 to 500 megabytes. This is a short-axis, three-dimensional echo view at the level of the tricuspid valve, and you can see some tethering of the leaflet here by the device lead. So it's a lot of information to sort through, and what would we use for this project? I was fortunate to receive a generous grant from the American Society of Echocardiography Foundation to support my work to apply AI to the subject of heart failure, and fortunate to collaborate with the scientists at Ultromics, this UK-based company using AI to evaluate echocardiographic images. Ultromics has already developed EchoGo Pro, which provides automated prediction for coronary artery disease from stressed echocardiographic images. Certainly a challenging subject that they took on. This shows an overview of the AI development progress from Ultromics. With the video that's input, they can classify the view, automatically contour it, and then select the end diastolic and end systolic contours and time. They can clinically measure global longitudinal strain, left ventricular volumes, and ejection fraction, and they've already characterized geometric features. So what was left is to develop heart failure prediction. We decided to start with an apical 4-chamber view and to apply machine learning to this limited view to determine if we could assess if diastolic heart failure was present. This view really contains a lot of information. You can see left ventricular systolic function, chamber sizes, left atrial size, the motion of the mitral and tricuspid annulus, septal motion. So really a lot of information that's available here. These are our initial results using 953 controls and 945 patients with diastolic heart failure and reserving 15% of the data set for validation and testing. This is our initial performance. The training AUROC was 0.957, and when we validated it, 0.877. So very exciting that we were able to detect diastolic dysfunction and recognize heart failure with preserved ejection fraction in this group of patients in this preliminary way. Let me just show you a couple examples. This is a woman with recurrent breast cancer and palpitations. Her apical four-chamber view. She had hypertension, hyperlipidemia, supraventricular tachycardia, and had received prior radiation therapy. So from this view alone, what would the likelihood be that this patient has diastolic heart failure? Well, our heart failure prediction score was very low, so very unlikely for her to have this, despite the fact that the left atrium is slightly enlarged and that she has had prior radiation. And when we look at the full echo report and the diastolic function, indeed, despite the mild left atrial enlargement, everything else looked good. Medial E prime was normal, E to E prime ratio normal, and there was no clinical evidence of heart failure in this patient. So got this one right. Now, here's another example, 52-year-old woman with a history of pericarditis who presented with dyspnea. She had a history of atrial fibrillation for which she was being treated with a beta blocker, and she was on colchicine and prednisone for the pericarditis. The heart failure prediction score from our model was very high likelihood of heart failure based on just this image alone. When we looked at the full echo, the left ventricle was mildly enlarged. There was evidence of non-compaction. Left atrial volume index was increased, and there was grade 2 diastolic dysfunction as evidenced by a high end pulmonary regurgitation velocity, low E prime, and a high E to E prime ratio. No constriction was present. And this fit with the patient's clinical picture also, with symptomatology consistent with heart failure and the genetic variant associated with non-compaction. So this is indeed a very, very exciting area. And how are we going to apply AI in the echo lab? At the point of interpretation of our echocardiograms, we have automated measurement of ejection fraction, volumes, global and segmental strain. But we're going to take this further to be able to detect disease and also report confidence in the measures that we provide. Next, we're going to link this with our electronic medical record database of outcomes. And so at that point of care, where the patient is having their echocardiogram, we will be able to provide estimates of the patient risk so that we can provide the best care for our patients and change their outcomes. Is this going to put echocardiographers and sonographers out of business? Well, certainly not. These findings, the echocardiographic images still need to be obtained with accuracy and care, and the findings need to be interpreted in the whole context of what is going on. But physicians and sonographers that use AI will likely replace those that do not. Thanks for your attention. Back to you, Dave.
Thank you, Dr. Pellikka. Great presentation. We're going to hear next from Dr. Asch. The COVID-19 pandemic has created a significant burden for healthcare and significantly affects the heart. And echocardiography is playing a key role. Dr. Asch will discuss the results of the WASE-COVID study that was presented earlier this year. And this is a multi-center study from the World Alliance Societies of Echocardiography, comparing human versus machine learning-based echo analysis applied as a predictor for outcomes for acute COVID patients. The AI was also applied to help clinicians more consistently measure ejection fraction and strain. And with that, I'd like to turn things over to Dr. Asch.
Thank you, Dave. It's my pleasure to join you in this roundtable today, and it's a real honor to follow Dr. Pellikka on her outstanding presentation. The presentation is going to be about the WASE-COVID study. The study was sponsored by the American Society of Echo Foundation, by the MedStar Health Research Institute, the University of Chicago, and with in-kind donations from Ultronics. Transthoracic echocardiography has emerged as the leading cardiac imaging modality for patients admitted with COVID-19 infection. Myocardial injury has been linked with poor outcomes in these patients. Therefore, an echocardiogram at admission may prove to be a powerful tool to predict death. The role of AI in cardiovascular imaging, and specifically in echocardiography, is expanding to facilitate image acquisition and image analysis. However, with reader-dependent technologies such as echocardiography, fully automated AI-based analysis should result in lower variability of results than those obtained from human reads. With increased interpretation consistency, it is foreseeable that the use of automated measurements could improve the capacity to predict outcomes. The aims of the WASE-COVID study were two. Number one, to explore the association of echo variables within hospital mortality in the phase 1 of the study, and on the second phase of the study, to describe the performance of machine learning-derived algorithms for prediction of death in patients admitted for acute COVID-19 and its incremental value to that of expert echocardiographer analysis. The study design, the first phase was retrospective. Patients had to be admitted for COVID-19 to the hospital. They had to be tested with PCR or antigen and test positive, and they had to receive an echo that was clinically indicated. The echo was acquired by the standards of each of the centers in the setting of the pandemic, and the analysis of the echo was centralized. It was done independently following the American Society of Echo guidelines. The second phase of the study was prospective. Once the patient was admitted and enrolled, the patient was followed up at least 3 months later through medical encounter, through the review of medical records, or through a phone call to the patient or the family members in the case the patient had died. The outcome was all-cause mortality. 870 patients were enrolled overall in 13 centers around the world, in 9 countries, as you can see on the right side of the screen. The echocardiograms, as I mentioned before, were obtained according to each center's standards. Most of the echoes were limited echocardiograms or point-of-care ultrasounds, but once the images were acquired, they were uploaded to the cloud to be subject to the analysis on the EchoGo core, the same system that Dr. Pellikka just described in the previous presentation. Bottom line, when the images were uploaded on the website, on its way to the core laboratories, and an analysis was performed automatically that would provide basically the left ventricular analysis. It was an AI-based that provided ejection fraction and left ventricular longitudinal strain. The standard analysis was also performed for each of these echo once the images reached the core laboratory, and it was done by 2 different readers. Each echo was read by 2 different experts. And then, therefore, we had 3 independent reads, 2 by experts and 1 by artificial intelligence for the ejection fraction and the longitudinal strain. The average of the 3 measurements was initially taken as the specific value for each echocardiogram. These are the baseline characteristics of this population. As you can see, these were sick patients. Actually, 46% of them were in the intensive care unit at the time of the echocardiogram, 27% were on mechanical ventilation, and 18% were receiving some kind of hemodynamic support. 62% of them had previous heart disease of some kind, including hypertension. In this slide, you can see the echo characteristics of this population. The ejection fraction was 60.2. The volumes and the right ventricular strain are mentioned here. I just want to point out that the analysis I'm going to be presenting here is specific to the left ventricle because that is what the EchoGo core could provide, not the right ventricle. The in-hospital all-cause mortality in this population was 22%. As you can see, mortality was lowest in patients enrolled in Asia, and it was highest in patients enrolled in Latin America and the United States. Left ventricular longitudinal strain was associated with in-hospital death, but left ventricular ejection fraction was not. As you can see here, these in different models of multivariate analysis, you can see the different clinical and echocardiographic variables that were actually associated with mortality: age, left ventricular longitudinal strain, LDH levels, previous lung disease, and right ventricular free wall strain. In conclusion, for the first phase, when measurements were averaged, left ventricular longitudinal strain and right ventricular free wall strain, in addition to age, LDH, and previous lung disease, were independently associated with in-hospital mortality, while left ventricular ejection fraction was not. When we looked a little bit deeper in this data, it was very interesting that if we would only take the measurements that were performed by the echocardiographic experts manually, neither the left ventricular longitudinal strain nor the ejection fraction were actually statistically significant associated with mortality. But if we only took the AI measurements, as you can see on the green highlighted there, the association was statistically significant. This really gave the room for testing our second hypothesis in phase 2, that left ventricular ejection fraction and longitudinal strain obtained using AI-derived algorithms will have less inter-reader variability and will result in a better predictor of mortality than expert readers would do. What we did to the analysis that I described before, we added one extra read by experts, and we added one extra read by the AI software. This way, from a manual analysis standpoint, we could test intra-observer variability because each echo was read twice by the same echocardiographer, and because the third read was done by a different echocardiographer, we could also test inter-observer variability. And the same thing happened on the AI. Now, by having two reads of the AI software, now we could test the variability of these algorithms as well. So in this prospective follow-up, 476 patients had echoes that could be read both by manual and AI analysis, and therefore we took those for the comparison of how each of the two modalities would perform for prediction. The follow-up was 230 days, and the mortality throughout this follow-up was 27.4%. As expected, the variability when using the AI algorithms was extremely low. The interclass correlation coefficients were very close to 1, which is perfect, and that was the case whether we were talking about the echoes in which the same frame was analyzed twice, or if different echo frames were analyzed twice. On the other side, the manual reads had much lower reproducibility with higher variability, and as you see, intraclass correlations and Pearson correlation coefficients, they are all far from 1. That held true both for the ejection fraction and the longitudinal strain. We further looked into which were the factors responsible for that variability, for that within-patient variability. Variance in AI was very small, and it was almost exclusively due to selecting different frames, which was the only step in the AI algorithm that can be influenced by a human operator. Once the human operator would say this frame is fine, then everything else would be automatically measured. The variability in the manual reads was, on the other hand, large, and it was mostly due to the different operators being the ones analyzing the images. When we looked at prediction of mortality through multivariable four-step logistical regression, you can see here that left ventricular ejection fraction and longitudinal strain measured by AI were significant predictors of mortality, while the same measurements done manually by expert readers were not, with p-values far from 0.05. The study has some limitations. Patients were enrolled in a retrospective manner. Not all echocardiograms could be quantified, and the image quality was suboptimal, considering this was at the height of the first wave of the pandemic. And the findings that we are reporting here may be applicable to patients with COVID-19, but it's unclear whether these could be applicable to other patient populations. In conclusion, automated quantification of left ventricular ejection fraction and left ventricular longitudinal strain using AI minimized variability. AI-based LV analysis, but not manual measurements, were significant predictors of in-hospital and follow-up mortality. AI analysis of echoes could increase the statistical power to predict outcomes, possibly requiring smaller sample sizes in clinical trials. I want to finish by thanking all the investigators around the world that participated in our study. Thank you.
We're going to move to Q&A now, and participants can ask any questions relating to the presentations and also about AI used in both of these studies. Also joining us now is going to be Dr. Gary Woodward. He is the Chief Technical Officer for Ultromics to answer any technical questions. As a reminder, you can enter questions using the Ask a Question window that is on your console, and we'll try to get to as many questions as we can before the top of the hour. We do have a couple of questions that had come in. You know, one of the questions I think overall that kind of summarizes a few that came in is, what are your views? What were your views and experiences of AI prior to getting involved with using this technology? Dr. Asch, maybe if you wanted to go first.
Yeah, I have to say that I have been working with different companies and algorithms for different aspects of AI for quite some time now. But I think overall, the understanding of what AI can do is very similar to what automation can do, although that is not really the case. AI can do much more than that because it can really put together multiple layers of information and data, and, for example, take that automated measurements, plot it together with clinical outcomes or with other clinical features, and give us an opportunity to diagnose and to prognosticate differently.
Dr. Pellikka?
Based on our experience applying AI to the electrocardiogram, I have been extremely interested and excited about how it might be applied to echocardiography. Certainly, the information that we have gotten out of a standard 12-lead ECG is far greater than what one would have expected, identifying various diseases as well as reduced ejection fraction and predicting atrial fibrillation. The echocardiogram contains so much information, it's just a matter of harnessing that information with AI so that we can use it to the full advantage. But I think that the potential is vast and extremely exciting.
And let me ask you a follow-up on that, because I've sat in sessions for years at ASE where I've heard over and over and over again about, in the new technology sessions, that echocardiography only uses this little tiny bit of the data, and the rest of it's kind of thrown out because this is what we need to reconstruct an image with the current computing technology that we have. So does the AI actually help extract more of that data? Maybe we have ways of looking at that data in ways that we never thought of 10 years ago?
Oh, certainly. You know, the expert clinician can look at a parasternal long axis view, for example, and derive just so much information from that just based on how that looks. The way the mitral annulus moves, the size of the right ventricle, all of this, the calcification of the valves, all of this is sort of integrated in the expert mind. But AI allows us to synthesize this information in a different way. And I think that it will eventually be the way that we interpret echocardiography, that it will be used by the clinician to assist their interpretation.
And Dr. Asch, I sat on one of your sessions at ASC a couple of years ago, and I think maybe 3-4 years ago, there's a lot of discussion about AI from an academic standpoint. I think a lot of your presentation back then was spent, you know, this is how the AI can sort cats and dogs and stuff like that, to kind of show the 101 level. But what are the discussions that you're having with your peers today on this technology?
Well, it is vast, because the truth is AI is such a general term that there's so much to AI that it is easy to think of AI as data mining and database evaluations and this and that, but it's much more than that. When we look at an echocardiogram, and as Dr. Pellikka was mentioning, for example, a parasternal long axis, we have a bias in that we go and look for the things that we believe are relevant. There's so much more data that we actually overlook because we bias it out. And a machine may actually have a fresh look, completely different one, that if it has the opportunity of link other pieces of information to relevant outcomes or relevant data, then the machine is going to help us because it can look much more than what our two eyes can. So to me, the idea of AI is an open-minded concept that we know what we have in front of us, but we don't know what comes forward. There's really a lot that can come out of any piece of data that we have.
One of the questions that came in from the audience, does EchoGo evaluate and quantify the quality and the rate of adherence to the echocardiographic acquisitions to the standard echocardiographic rules? I don't know who wants to take that.
Maybe Dr. Woodward may want to take on that. Gary's trying to talk, but
are you muted? Yep, there we go.
Maybe we go to the next question, and then when he connects well, we go back to it.
So another question from an attendee is, how do you deal with the very noisy nature of echo video? Does the AI, from your experience, have you guys seen the AI being able to see through this? Because you had mentioned in previous conversations that you had a lot of point-of-care ultrasound that came in your study.
Well, let's be clear, this is echocardiography. So if the acquisition is inadequate, everything is going to be inadequate from there on. That being said, I want to point out to two specific things that were discussed in this presentation. EchoGo Core specifically, and I'm not talking about other systems because each of them is different. EchoGo Core has been validated, has been developed and validated in stress echo. Can you think of a clinical situation in which the echoes could be more challenging than the patient exercising or right after the exercise? And a similar, and to be honest with you, that is one of the reasons why I, as an investigator, thought of EchoGo Core when we needed to analyze the COVID data, because we knew there were going to be a lot of limitations in image quality. We all know what it is going into a room with a patient that was diagnosed with COVID that is on a mechanical ventilation, and all the risks that that takes for the sonographer or the operator of that machine. We want them to come in and come out as fast as possible, and there's a lot of challenges on image acquisition. So I feel good about how this specific technology works on it. I don't know, maybe Dr. Pellikka has some other ideas or comments about it.
Yes, you bring up a good point. The COVID echoes certainly have been a challenge. Technically difficult echoes on very sick patients with lung disease and who are on ventilators, performed at the bedside. And then also when there were recommendations to sort of act with the patient, especially early on in the COVID era. So this was a great test of AI in the study that you conducted. I think that some of the challenges about variability in echocardiographic images and noise are best going to be overcome by just using very large amounts of data. And we want our AI models to work for everyone, not just for patients with good images. So this is going to be very important.
Hello.
Dr. Woodward, are you online?
Yes, can you hear me?
Yeah, I can.
Hi, yeah, sorry, the microphone seems to not work. I've just dialed in.
It's okay. So the question that I asked earlier was, does EchoGo evaluate and quantify the quality and the rate of adherence of echocardiographic acquisitions to the standard echocardiographic rules? Yeah,
I mean, I think that's a really good question. And I'd say that one of the important things that we acknowledge at Ultromics is that echocardiograms come in a whole range of qualities for various reasons, and the acquisition is an important part of that and can be difficult or easier depending on the situation. Our technology comes from an original ambition to process stress echocardiograms, for which we have a product. And most of our processing technology comes off the back of processing these stress echocardiograms, which I think all the listeners who know echo will appreciate. These are probably the worst kinds of echoes you can take because the heart rates are really high, the patients are moving around, often overweight and things like that. So we developed the technology specifically to be cognizant of these quality issues. And in addition to that, we're probably unique in the space by providing our technology as a cloud-based software as a service. And in that way, not only do you get the outcomes of the medical device, which may be a quantitative measure like global longitudinal strain or EF, or disease prediction like coronary artery disease or heart failure, as Dr. Federico said, but we also can provide information back about these quality metrics, and indeed have a whole work stream that is related to quantifying these quality measures of echocardiograms. So you get both the AI and experience view back as part of using our service because of that.
Another technical question that came in and says, what are the frame rate requirements for reliable analysis using the software?
Yeah, I mean, that's another good question, one we get asked often. I would say that the thing to bear in mind as far as we're concerned with the application of AI is it's not just the frame rate that you require with. Obviously, it's the frame rate in relation to the heart rate that you're taking the image of. And again, this hails back to our days of focusing on stress echoes. So we intentionally designed the technology to work on quite high heart rate images. So rather than say a specific heart rate, I would say that what we require is that you have at least 3 frames between the end diastolic and end systolic portions of the cycle, in order to, of course, we can quantify on less than that, but we feel that that's probably a measure by which we would be satisfied that you're going to get true and accurate results. Because anything less than that, you're not quite sure if you've truly caught the end diastolic and end systolic frames.
The other question that came in is, will EF assessment in circumferential strain be incorporated into the AI evaluation for POCUS?
Pardon, could you just repeat that?
So will the EF assessment in circumferential strain be incorporated into the AI evaluation for POCUS, the point-of-care ultrasound?
Our technology can already be applied to POCUS systems, which indeed includes ejection fraction and strain, if I get the question correctly. And I suppose Dr. Asch could talk to that as well, in the sense that the COVID study exemplifies that, because many of the reads that were taken in these COVID patients were indeed point of care or rapid protocol systems, for which we show EF and strain correlated outcomes.
So if I can comment on that, Gary, just to provide data behind that, out of the 13 centers that enrolled patients in the WASE-COVID study, 11 of them were only doing limited echocardiograms, or you could call it point of care if they were taking at the point of care, which is really the case in COVID, but they were limited echoes. So you get an idea, the average number of video loops that were acquired on each of these echocardiograms was 32, which is way far from what a comprehensive echocardiogram would include in any of these centers of excellence around the world, or at the Mayo Clinic, or here in MedStar, I think anywhere. So the results we have shown are indeed at the point of care, whichever way you want to call that scenario.
And just to expand on that, Gary and Federico, you didn't even require an electrocardiogram signal to link with the echo images, right?
Yeah, that is correct.
Good point. Thanks, Patty. Yeah, I mean, we've developed our technology to not require ECG leads in order to calculate the cardiac cycle and also identify end diastolic and end systolic frames.
Another question that came in is
uniquely applicable to POCUS, I think.
Another question that came in was, does the frame rate become a limiting issue for GLS assessment? And does GLS, from one view, have sufficient predictive ability using the software?
If I could answer that, I guess in simplest terms, I guess traditionally, if you want a global longitudinal strain, you might say that you need both 2, 3, and 4 chamber views. However, we've done significant research in this area to show that you don't really need, or it seems that the correlation of strain to outcomes, particularly in the case of, say, this COVID trial or other clinical outcomes in terms of myocardial infarction, coronary artery disease, which we focus quite heavily on and done some work in cardio-oncology cases. 2 and 4 chamber views are often what we will see and what would often be quite well and more closely associated with outcomes, and even taking all 3 views. I think because there's a significant error that comes from trying to acquire an adequate 3-chamber view and the avoidance of foreshortening in some of these views. So in fact, providing a technology that limits perhaps the number of views to acquire these strain measurements is probably advantageous and overcome some of the acquisition issues. So we show good correlation to outcomes with single view strain rates, as well as 2 and 4 chamber strain. Indeed, the COVID study that Federico just presented was focused on strain from 2 and 4 chambers.
And I know, please allow me to expand a little bit further, because we're talking about AI, not only about EchoGo Core. There are multiple other platforms that can also measure ejection fraction. And what we are learning is that you can actually calculate ejection fraction, for example, even without measuring volumes, or just from a parasternal long axis, because again, the algorithms that are being used take into consideration multiple other pieces that are not what we are used to as clinicians. So this goes back to the concept that we mentioned before, in which we need to we need to open our eyes to interpreting images or echoes in a way that is different from what we do on a day-to-day basis. We need to be open, and we may be able to find things that are very relevant.
Another question that came in is a question that I've had frequently when doing interviews on AI is, does the company see benefit to rural hospitals where access to qualified echocardiographers is limited? And I know with AI across the board, it helps with reducing interoperator variability, which has been a huge problem in echocardiography, especially from the physician standpoint. I mean, you guys work at major centers, but what do you see as the applicability of this technology for rural hospitals?
I think that's a question, Dave, because there certainly are, now that we have portable ultrasound devices, and the utility of echocardiography is widely recognized, and it's needed in remote areas. I think this is a great potential application to apply AI to the images to increase the standardization, to make sure we're all saying the same thing about ejection fraction and volumes, and that even places that have less experience are able to assess diastolic function and recognize rare diseases, which eventually will be a goal.
Yeah, I mean, thanks, Dr. Pellikka. And I would just continue on saying that if we expand on the notion of expertise and the availability of expertise, we know that the expertise in echocardiography is becoming few in relation to the demand, the growing aspect of disease. And we've looked at this specifically, right? And I think there's two elements to this. One element is the fact that we provide the technology in a software as a service scenario, and in this context, that means that you don't need any specific hardware or specific software installations or specific expertise to use the software as you might do with other strain packages. So an echocardiographer that understands how to measure strain in order to use those packages. So in that way, I think we're quite accessible to the whole the whole diverse range of hospitals and centers that might need to use this technology. But also, second to that, we've actually looked, and because the technology is being rolled out and has been developed across the NHS as an exemplar, which includes both expert centers and local DGHs, we know and we've seen that what happens is by providing this technology and the AI providing some indications of quality and of outcomes relation, the novice or inexperienced echocardiographer actually seems to start performing at the level of a more experienced echocardiographer or expert clinician. So, you kind of start to see an improvement or an increase in agreement across centers, which is important to show. So you're almost intrinsically providing the standardization, but also you can see the increased quality of care that these non-specialist centers start to provide through the application of these technologies. And I would say that because we also provide a service, not just the software, our technologists that go into the center to help them, work with their images, get to better quality images, all of these add-on benefits that we provide through the way that we provide the AI, all adds to how this kind of technology can improve both rural centers and bring them up to the standard of a specialist center, at least in this specific area of echocardiography.
Another question that came in, does Ultromics provide a quality rating or automatically reject or identify inadequate images?
Yeah, I mean, I think that is related to one of the earlier questions you asked, in the sense that we do provide information related to the images that come into our service. Expert reports on the image quality, but also should be in future versions releasing indicators of image quality if that seems useful to the market and users. Yeah.
In a related question to that came in from another viewer is related to poor image quality. Can the AI help at all with heavier obese patients? And also, can images using image enhancing agents, contrast agents, be interpreted by the AI as well?
Yeah, I mean, the short answer is yes. So our technology, as I said before, was born out of stress echocardiograms, which is that key demographic of very hard images to acquire, overweight populations, generally speaking. So we've almost trained our technology for such poor image quality, and we don't generally see a correlation between image quality and the quantification outcomes. So we believe our technology can work very well in poor image quality acquisitions, and have shown that in the recent publication that should be coming out shortly. And indeed, our technology has been trained to quantify and work on contrast echocardiograms, which is cleared in the European Union for the application, and working with the application of that in the US. But generally speaking, yes.
When comparing AI to conventional measurements by echo, for example, strain, how does one establish a gold standard if an outcome, such as in the COVID study, is not being studied?
I think that's a very good question, and I think it buries down into one of the key areas of echocardiography, in the sense that there isn't really any gold standard or way of really understanding what the true value is in a quantitative sense, both beyond just strain, but all the measures, right? There's no say if you use MRI, you'd use a real anatomical phantom or something to get these measures. So I think what is important to us at Ultromics, and I'm sure our collaborators would agree, is that we're really concerned about how our measurements reflect what is really happening with a patient, right? So if a patient gets sick, if a patient gets healthy, do their cardiac measurements reflect that? And more importantly, in outcomes, right? Both in hard outcomes and slightly softer outcomes, but death, morbidity, myocardial infarction, more cardiac-related events. So most of our proof points and building towards evaluations is to show that our technology really reflects true clinical outcomes, which I believe is the real way to show accuracy of these technologies. And I'm sure Federico Asch, Dr. Asch will say that the COVID case has been a great example of this, because there was a huge amount of hard outcomes in that particular data set, which happened in quite a short time frame. So you could really make close associations between patient outcome and the measurement that you're taking. And through that, I think this is one study among many that we're doing that exemplifies that kind of outcomes-based true standard of quantification over and above, comparing to a predicate or clinical practice as it might be.
Another question that came in is global longitudinal strain from only one frame sufficiently predictive?
Pardon?
Is global longitudinal strain, the GLS, from one frame sufficiently predictive, or does the AI need multiple frames from a study?
I think it depends. Oh, sorry. Go ahead, Gary.
So I mean, I'm happy for you to say that, Federico. I was just going to say that our technology doesn't use just one frame. It actually, we've purposely designed it to mimic what a echocardiographer would do in their clinical workflow. So it will identify all of the frames in a cycle, and it will decide which two are the end diastolic and end systolic frames, and then from that calculate the global longitudinal strain in the ways that we normally do, in a classical sense with ecclesial distances. So we don't actually use one frame, and I would doubt very much that you could quantify strain off of one frame. You need the temporal nature of the echocardiogram in order to understand what's going on with the heart. And I don't know if you'd agree with that, Dr. Asch.
Yeah, absolutely. By definition, strain and strain rate are measures of shortening, and you cannot do that on a single frame. If I take a picture, you will never be able to tell me how fast the car is going. You need to see it moving, and that's exactly what Gary was saying, and I fully agree with that.
If I could interject just one question, since we're getting towards the top of the hour. One of the things I wanted to get from your perspectives was just everybody's been talking about AI at ASD and RSNA and ACC for years, but you guys are kind of in the forefront in the trenches using this technology and helping develop it and kind of push the envelope of the studies. Where do you see AI realistically being in 5 years, and how is this going to change people's standard of practice at their labs?
I will start there. I think here is important to focus on the clinical value more than the accuracy and anything else. And I think it's up to us to be able to prove what the clinical value of these new tools are. And when I say us, I mean this is really a collaboration that we need to have scientists with industry, with engineers, and that is why I personally value so much the very collaborative approach that Ultromics and other companies in this field are having. They understand that the real value of these things is not about how accurate the EF is. It's about what the clinical value of implementing these novel technologies is, what ultimately will prove how powerful and how valuable these tools are. And that may take more than 5 years, probably will. But I think in 5 years, we're going to be much closer to our ideal, if you want, than what we are today.
I would just add that we will also need to make sure that the tools are developed in large populations that really reflect global populations, not just the bias that might exist in a regional population or local population. We want to make tools that are going to work for all patients. And outcomes are really the endpoint that is most valuable because the outcomes should be available in all.
We have time for maybe like 1 or 2 questions, and then we'll end the session. But during the training stage, would you need a segment? Would you need to segment every single frame manually by the echo expert?
Well, traditionally that's how you would do it, and that's how we started doing it. But as you gain the technology to process these images, there are alternate ways of doing it, certainly. But at the end of the day, to start with, you really want to have a very good understanding of the problem you're trying to solve. And I think in terms of understanding that, you really need to have a good understanding of the behaviors of the current clinical practice and the application of technology. In this case, echocardiography, and in the case of quantification of echocardiography, the traditional manner is to segment out a particular anatomy in one way or the other, either take a cross or a straight line measurement, or to contour the left ventricle in our case. And so we spend a lot of time researching and understanding how the manual process of contouring echocardiograms is done, and from that form the basis of our technology, but then move beyond that in terms of how we could improve on this, both to understand how we could better interpret what the true contour is, because there's a lot of variation amongst what people think are good and bad segmentations of a left ventricle or whatever anatomy it might be. So how do you solve for that consensus issue that arises? And then also beyond that, in creating bigger data sets that don't really necessarily rely on the manual process. So we started there and moved beyond that.
And Gary, I could talk with you guys all day about AI, and there's still probably a dozen or so questions we haven't got to that we won't be able to take in. But I guess the bottom line for a lot of institutions is, what does Echo Go cost? I mean, what is the cost of this technology if somebody's interested in implementing it?
Pardon?
What's the cost of the technology?
I think that the technology is freely available, or not freely available, but is available to the US and European markets, and we'll be happy to put you guys in touch with the commercial teams who could work with you on an appropriate pricing model for this, but certainly accessible to all centers from a pricing standpoint.
Well, I appreciate everybody's time. We're at the top of the hour, so we're going to cut off questions here. Any of the questions that we have not gotten to, we will answer those offline. On behalf of DAIC Magazine, we would like to thank everybody for their participation today. So long, everybody, and thank you for attending.
Thank you so much.
Thank you.